A lot of you have been involved in the Community Health Improvement Plan that has been going on for the past few years, doing the assessments, getting it up and running, and the key person that did most of those assessments is right here. But all of you came together and you're making a huge difference, and this is the culmination of that. You chose 3 priorities. They were policy and funding, chronic disease, and access to health care. Just a quickie, policy and funding will be having a meeting December 13th from 2 to 4. They'll be going over what their talks are going to be, their informatics, data briefs on the bills, and doing a collaborative on moving those forward, including the BMI, the EMS funding, and such as that, the e-cigarettes. Access to care, that has taken off like a tsunami. I don't know if you're aware, it actually has 3 components to it. Getting a 911 nurse call system in, getting help for the people that are out there that don't have the help, making sure we have the providers so that if they do have access, they can get to a provider to help them, and third, to have insurance so they can pay for that visit. So over these last couple months, because this has been official and rolled out in August, so essentially since July and August, we now have 500 people that are part of this process. This has been a true turning point in this community. We're seeing the intersectorial collaboration at a high level, a new level that we've never seen before, with unusual partners that you don't expect. And you guys have made this come to fruition. Access to care, the insurance program, they have a new strategy where they're defining exactly who and where these people are and what their demographics are, so they can more readily access them when they get them to enroll. We also have the primary care providers, the mental health workers, and the dentists. We have maps. Our map people are here. They have made amazing maps. It shows not only where our providers are, what they are, how close they are to a bus route, how close they are to special transportation. So we really clearly can see where these gaps are now. Those 2 groups are meeting on December 14th from 2 to 4 p.m., and they will be coming up with a clear strategy to get to these people. The final one is the biggest, and probably at one point was the hardest one. We never thought we'd get it into place, but certain people here have really taken the bull by the horns and moved it forward. And that is the nurse call system. And Sarah McCrae will go into some more detail on that. And I have to thank her bosses, Chief Slatterly and Chief McDonald, for allowing her to say, I have this vision, and they say, it's great, let's do it. And they have given her full support in getting there. So, and thank all of you for keeping it moving, keeping the funding going, saying, I can see this clearly, I can see where we can go. So, Sarah, go ahead.
Thank you, Adele. That was a really great introduction to the CHIP, so the Southern Nevada Community Health Improvement Plan, and it has been something that we've been working on for a couple of years in our community. And yes, the Access to Care group has had a lot of energy even from the beginning, and we very quickly, in partnership with Troy Tuke from Clark County and Scott Bevere from the City of Henderson Fire Department, identified your first responders are out in the field responding to these calls and to the people that are vulnerable in our community and don't necessarily know where else to turn. And when people don't have insurance or have access issues, they're using the 911 system. So it's very appropriate that your 911 community is coming and as a forefront into the public health sector and working with the public health partners and identifying who these people are and what are some creative ways in which we can address their needs. So this Nurse Call Line is a program that's working in several different communities across the world over, and our fine guests here today will go into that in some detail. But just to give you a little bit of perspective and where this Nurse Call Line will be housed upon implementation is at Las Vegas Fire and Rescue Headquarters, because we happen to also be the location of our combined communications center, which handles all the 911 calls for service to our 3 largest fire departments, North Las Vegas, Clark County Fire, and Las Vegas Fire and Rescue. And that alarm center processed nearly 500,000 calls for service last year. And we'll go into some of the statistics in terms of how many people will be able to help with a system like this. But even if we just have this nurse call line implemented as a 911 redirect, where they call 911, it's identified to be a low priority call through a very strict set of protocols and very strict set of questioning. We identify this caller to have a low priority need. Happens all the time, every day, rather than having to send out an EMS resource and transport that individual to the hospital where it's not necessarily going to meet their needs, right? This EMS system is for these really high acuity, high needs patients that need immediate health care, immediate emergency health care. They go to the hospital with these low priority needs, and it's costing our community, from the call to the 911 center to the response to the hospital, and that they maybe don't even have insurance. We're not addressing those needs, and they're not getting the social needs addressed that may have created the crisis in the first place. So this nurse call line is really an alternative in getting these people redirected to the services that they need most. And so I will, without further ado, and thank you for the support in this community. Because of many of you in this room, I wouldn't be standing here today. This wouldn't be a possible reality. You've been so supportive as we've moved through the community, asking for help and asking to have a shared vision of how we help our community as a whole and come together and break down these silos and really have single solutions that can be regionally applied, which makes it easiest for our community to navigate, right? Our system is otherwise sometimes very complicated to navigate, and that's really where this is coming from. We need to make it easy, and we need to do it right. So I would really like to introduce our guests here today. They are going to tell you about this amazing program that's going to make such a difference to our community. And as they're presenting it, just think about how it's going to positively affect you, your community, your neighbors, your friends, family, and also you professionally as a provider, and however it is that you're related to providing the most appropriate resource to our community in need. Thank you.
This is exciting, and I want to thank you so much, sir, for reaching out to us about our program. My name is Gigi Marshall. I'm a registered nurse, have been primarily nursing in emergency rooms, have ran a couple of them. I was a nursing professor until 2 years ago when I happened to hear about this during a pedicure, serious, and told the person, gosh, I'm probably the person you want to run that. And I was kidding, but as it turned out, I really wasn't. This is exciting both as a tract for nurses, another way we can use our knowledge, but I think moreover it's really exciting for the community. My background, again, is primarily emergency critical care nursing and education. Before I get into the slides, though, I do want to introduce you to my colleague. And this is a very modest gentleman that I'm going to blow his horn because he never will. This is Dr. Conrad Fivas. Dr. Fivas was approached over 15 years ago, working in 2 different ERs, ambitious ER doctor, fresh out of med school, and his talent was noticed by an administrator who approached him and said, what do you think about writing protocols with a professor from Harvard and Stanford? And and making a lot more money. And so he was game for that. So for years, Dr. Fivas, two weeks in San Francisco, 2 weeks home. 2 weeks San Francisco, 2 weeks home, and establish these protocols. But I'd like him to tell you just a little bit before we get started, if you would, Conrad, a little bit about how these evolved and the expertise behind them, because this is what gave me the confidence to jump ship and change directions in my career.
Thank you, Gigi. Yeah, so back in 1998, we went to San Francisco, worked with these 2 doctors, and we created about 200 odd of these protocols. They're symptom-based protocols. They work on exclusion of a condition. If we can't exclude that condition safely, that's where we will exit. So subsequently, we went to the NHS, the National Health Service in the UK. We were part of a tender for the supply of clinical content to their fairly ambitious nurse triage project that they were embarking on. And we were successful with that tender for the supply of the clinical content. And on that base protocol set, they've taken subsequently just over 80 million calls in the last 15 years. That's only England, Scotland, and Wales alone. But we also implemented in other countries, in Australia, there in Queensland. They've been using our software now for just over 10 years. We were asked to be part of a tendering process because the commissioner said you can't use the same supplier for so long, you have to go out to open tender. 15 companies tendered, and we were successful again to supply them for another 5 years with the content. So that's just a little bit of background about the content and the development thereof. Gigi, you want to continue?
So let's talk a little bit about why ECNS, and then we'll get into a little bit about how it works. Well, there's a supply and demand mismatch for anyone who works EMS, ERs, anywhere in healthcare. And there's an interesting chain of events that starts going on in the 911 system when a call comes in And then in most centers, what happens? An ambulance gets dispatched, sometimes sooner, sometimes later, but that's usually what happens. And then the ambulances start leaving the bay. They're tied up out in the community. They start handing off patients in the ER. Sometimes that takes a little bit of time in and of itself. We'll talk about that. And then what happens is you have fewer ambulances available for when true emergencies come in. And it's not to say that everyone calling 911 is doing it because they're just wanting to clog up the system. It's been the way we've done things. That's been what we've expected. We call 911, an ambulance comes, and that's what we get. So London Ambulance Service did a study, and in this study they used 3 different methodologies trying to look at outcomes. They looked at the people who called in, and then what they did was they did assessment by the ambulance attendant, so it might be the paramedic who's on scene. They did assessment by the senior physician in the ER that received the patients. And then retrospectively, a chart review was done to look at what was their real diagnosis and how acute was this situation that they presented with. And there were 15.7% of the cases that were universally deemed by all 3 methodologies to be inappropriate. And this 15% to 20% number is something you're going to see reappear. And that's kind of what we keep seeing out in services, is that's about the amount of calls, too, that our system gets shunted to and manages very nicely, percentage-wise. Approximately 50% of the cases had at least one of those 3 elements say this really didn't require a 911 ambulance emergency response. So another way to look at that is almost up to 1/2 of the cases might have been handled outside of the EMS, depending on which outcome measurement you used. Even using what this study called a very conservative definition of medically necessary transports, 15% of those patients transported by ambulance to this particular hospital using the London Ambulance Service did not require EMS transportation. And I'll just deviate a second here on medically necessary. When I started looking at the research onto what are they determining as medically necessary or not, some of their definitions were as narrow as if you clip a pulse oximeter on someone's finger, whether or not they had a breathing problem, they now are medically necessary. So you can see that it can be used very, very loosely in what the definitions are. We've got studies that show percentages of transports where not one single vital sign was out of whack. Not that vital signs are everything, but they are vital. Emergency departments have long been used as safety nets for health care. And for many people across the world, this is really their only access point. The Institute of Medicine termed emergency departments that see more than double their share of Medicaid patients as the safety net of the safety nets. So here's what our safety nets, or our EDs, are experiencing today. Right now, there's an increase in ED visits between 1997 and 2007, 23% increase in visits. Adults with Medicaid accounted for the biggest increase in users. The Affordable Care Act has also resulted in increased ED use. And this increase in the total number of ED visits was almost double what would have been expected just by population growth alone. In conjunction with that, we've got an increase in ED closures. So between 1998 and 2009, the number of hospital-based EDs in the U.S. declined, although there have been some freestanding units that have started to emerge because of need. Non-rural hospital EDs have declined by 27% in the U.S. in the last 10 years. And the safety net hospitals, those that receive the double or more, their share of Medicaid patients, are the hospitals most significantly at risk, and they're the ones that are getting the most patients. So again, that supply-demand mismatch. And then the other thing is, those of us over 50, we're not gonna say die. We just keep going. Population of aged patients increasing. But here's what happens when older people get in the ER. Anyone work in an ER or ambulance transporting? Out in the audience here? Okay. When you get an elderly person, and that term is becoming really dear to me, but when you get a person who's a little older coming into whether it's the ED or even on the ambulance rig, more resources are needed. more things start to break down. We start to get complex medical histories. We're on polypharmacy sometimes, and the drugs themselves can cause problems. So when that patient comes into the ED, there is a myriad of tests that start to be done. So when the elderly people go into the ED, what we've seen is there's an increased number in patients that leave without being seen because they're not attended to quickly. And there's also an increase in waiting for all age groups across the board. So this problem isn't just a lot of people calling in, it sprouts arms and legs, tentacles. And then we talked a little bit earlier about when you go to, you're in a rig and you've got a patient, you take them to the ED, and very rare is it that the nurse is right there ready and there's a bed ready for them, and you high five and off they go. There were some studies done in a California hospital, up to 6 hours handoff delay. So that is 6 hours that a rig went out, picked up someone, and there they sat in the ED until someone could relieve them. So this congestion, again, starts to have exponential effects. So here's another way to look at the cascading flow of low acuity calls. There's a lack of primary care capacity, or at least limited access to care, which leads to increased 911 and emergency department utilization. And that in turn leads to longer EMS turnaround times and hospital diversion, a decrease in available 911 resources for the critically ill, and an increased cost of care and a decreased quality of care. The arrows are all going in the wrong directions on every one of those matrices. So here's what the International Academies of Emergency Dispatch has proposed. They say, why don't we look at doing a secondary medical telephonic triage system? And I say system because it has multiple components. One of the most important ones is protocols, but what we discovered is there's actually several things that need to happen. And I will argue that that is why we win tenders, is because it isn't just a group of guidelines. Here, give these to a nurse, or you know, train someone out in the public and have them kind of read these questions and they get dumped into a category. This is more comprehensive than that. A quick overview is the call comes into 911, and off to the right on your screen, we're in the kind of pinkish color, emergency ambulance response. Typical what people expect to get when they call 911. However, if you look at the down arrow, what you see is if it meets certain criteria, and we'll talk a little bit about what that criteria looks like, then they may qualify to go to a nurse for further triage. And then if, after this more in-depth questioning by a clinically trained professional, determines that another disposition or an alternative transport may be beneficial to this person, then that will be the recommendation of the system. Dr. Fivas and I penned a paper looking at the research and also looking at, frankly, the outcomes from the ECNS itself and the protocol base that has been used for 15 years. And what the Academy has endorsed and what we found in our research is that the 4 following things should be in place if you're going to be using a second-tier system. And the first is those clinically sound protocols, tried and true, research-based, a standards council that they go through, constantly updating and improving. It needs to be based in an emergency communication center where you've got the EMDs communicating with the nurses with the EMDs. We're not a territorial thing, we're all here together, and we're all working for the same outcome. It needs to be a trained, registered nurse. At first, when I looked at the protocols, they seemed so comprehensive. I'd worked in a number of ERs and ran a couple of them. And the questions they asked were exactly lining up the usual suspects that I'd seen done in whatever state it was I was working in. But the more I looked at the system, I actually went down and identified 6 or 7 different places in it that if you had a clinical expertise, it could be a pivotal point. And I am absolutely convinced that even though we've got such a comprehensive, highly stratified set of protocols, you still want it governed by a thinking, knowledgeable expert. And then the other thing that needs to happen is the medical oversight. And so part of the structure of the ECNS is that there will be a medical director who will be over the nursing branch of the EMS, making sure that the protocols that are selected for your community, that director feels confident and can stand behind. and that if they've got changes or they've got questions, that you've got someone that the nurses can go to and that can go to the nurses for that two-way communication. So the 911 call comes in. If the criteria is met, the dispatcher will see something like this on the screen with the pink box that alerts them that this call is ECNS eligible. And so there'll be a script that will be devised. Typically it's by the agency that is managing the system. And it's something like, you know, it looks like you meet criteria to speak with the nurse. Could you hold a moment and I'll transfer your call. And then the nurse, the call goes into the nurse's queue and the nurse picks up the call. Where again, this nurse, we recommend that they are acute care. I have a kind of, I guess, proclivity to like emergency nurses. That's my background. And, but I think any nurse who is able to critically think and who has seen what sick people look like versus not so sick people. So when these descriptions are coming in, you actually can get a visual. Someone tells you a baby is laying there limp, that's all I need to know. A 3-day EMD certification course to this experienced nurse, and then also a 3-day ECN course. Now the EMD course takes the nurse through the credentialing of an emergency medical dispatch. So the nurse will actually be trained as a medical dispatcher before being trained as an emergency communication nurse. And this is important, I think, for several reasons. One of them being that you understand the role of the dispatcher, but also a caller can deteriorate while on the phone, and you may need to be giving life support instructions, so you do need to be trained into that and know how to go back and forth between the low acuity and back to the high acuity as well. So here's how it works, and this is kind of little print. Hope you can see that okay. But let's follow the little red boxes for a minute. 911 call comes in. If it is a high acuity call, calls we code as Echo, Delta, Charlie, Bravo, and a handful of alphas that have not yet been approved for ECNS. All of those will continue down the regular path through the dispatcher in determining when and how soon and what kind of a crew will be sent out. However, if the call does meet ECNS eligible criteria, which will be all of the Omega codes and I think it's 88 of the Alpha. I've got it on a slide, the exact number that have 50 odd, and then 88 Omegas. And then if they meet that criteria and after the questioning, it's determined that we've come to what we recommend for your level of care, any one of these categories going down that side of the screen can occur. And the reason it's so highly stratified is because how in depth our questions are. We feel confident in where we're saying we recommend. And then there's other safety nets built into this, and we'll go over those that I think will give you comfort in, wow, this is kind of new, a nurse determining this. No, there's more than that going on behind the scenes and also in front of them. The ECN will recommend, based on what the system tells the ECN and also that ECN's professional clinical judgment, what the best outcome would be for that patient in regards to transport and where they go. So the determination of where should this person go is one of the outcomes of the system, and what's the best way for this person to get there. I was so enlightened and happy to hear that this is a community effort, and you're looking at maps with transit and different access points, because that can be where things halt. You may have a beautiful plan, but if they don't have a way to get there, are we back to the ambulance's taxi? So that you're looking at it that holistically is very commendable. The ECNS is governed by the International Academies of Emergency Dispatch, and this is the nonprofit portion of the entity that's associated with our company. And with any other discipline, just as with ECNS, these protocols go through a council of standards. If there are changes that are recommended, and we recommend, we empower the nurses as we're teaching them. If you see a better way to do something, or you're wondering, this seems redundant, or why aren't we asking this, go ahead and put a proposal for change, and we'll look into it. And it's great when the partners even do so much as to furnish the research worth it too. But you can bet that anything that does get changed goes through research, and it also goes through a panel of experts, medical experts around the world. And I've had the opportunity to sit in on a couple of those, and that's been fabulous as well. So the codes that were determined to be safe to be sent to the nurse are the following: 88 omegas and 53 alpha level codes. So there may be up to 141 different codes that could be sent to the nurse that have gone through the rigor of being research tested and validated out there, again, through this protocol set that has been around for a number of years, although it keeps, we think, improving. But the local medical director will determine, well, you know what, this one, I'd rather not go there yet, let's get our feet wet. So there is that flexibility to make sure it's custom for your agency. And then over in the white print, it's a little bit about an interesting study. We refer to it as the Alpha study, because what this study was looking at is, how do we know that alpha codes are safe? Omegas, sometimes we don't send anyone out on an omega anyway. So the omegas, more comfortable with, but the alphas, how do we know that they're safe? In the study, there were almost 17,000 cases that were reviewed, and this was in retrospective chart review. 89% of these cases did not even have one vital sign that was unstable in the patients. Only 1.1 of those cases were transported lights and sirens. And with the exception of the seizure protocol under alpha, all of the other alpha protocols studied were seen to be very safe and effective in the ECNS. We believe the secondary nurse triage process should identify those few at-risk patients that exist in low acuity calls. And the way they're structured is to rule out the most life-threatening and most probable for those symptoms conditions first. And that's how we get that kind of confidence and the same kind of results. And I guess want to leave you with the thought that there are many systems out there. I didn't know there were 15. That was stunning when we found that out. We're like, who are they? We know like 5 of them that are kind of floating around. But we are the only ones we know of that have the soundness behind the protocols, which is where it all begins, that demand it be placed in an ECC, and that use a trained registered nurse with the program and certification standards we have, and that insist upon an active medical oversight. Talked a little bit about that stratification, multiple layers. There's 212 different protocols that the nurse may choose from, and this is all done in a software program. Some of the protocols, like with the MPDS, used to be on the card sets that you'd flip through. You can't flip through 212 of them. So it's only software based. Multiple recommended care levels, and then there's sub-tiers of care offered. We also have an extensive instruction home care self-care bank that helps them to do interim, or sometimes, hey, try these things, and if you get worse, call back, and sometimes home care alone will do the trick. We call the software we use low code, and it is what's termed a clinical decision support software. And key in that phrase is the word support. This is where we differ with individuals and agencies who believe you can use an EMD, and there are that going on in other countries, and they're not having as good of results as they could have otherwise. But we do believe that you need to give a very good structure and platform for the nurse. But as I said, 6 or 7 places in the call, a clinical judgment comes into place. It might be that I heard her say, my mother was involved in a fender bender and the side of her neck's a little stiff. But then when she tells me her mother is 82 and her mother's on Coumadin, I'm suddenly a little more concerned than if her mother were 45 and not on a blood thinner. Because of the fragile veins in the skull, I'm now going to think I might also need to ask some questions about making sure there might not be a subdural or something going on, a bleed of some kind. Let's see. First live implementation in South Africa in 2001. Dr. Conrad said, 80 million in excess calls. And then these protocols do go through the Council of Standards. We've had 2, I think, since I've been here. They're usually about once a year, once, twice a year. And then of the 212 protocol sets, the 5, and this is just kind of interesting, most frequently used: falls, help, I've fallen and I can't get up. Abdominal pain makes a lot of sense because tummy aches hurt, and they can hurt really bad. And depending on what's going on, it might be emergent. And there's so many organs inside that abdominal cavity that to try to make a guess of what's going on is often very difficult to do. Back pain, vomiting, and leg pain. So here's what it looks like behind the scene, the algorithmic decision tree. This is a screenshot of the decisions going on behind the scenes for when someone phones in and has some blood in their vomit. We call it hematemesis. And the legend is showing you that, this is hard to read, and you can see it's kind of UK because it's got those extra vowels that we don't use over here in hematemesis. So the first thing that's going to happen when someone calls in and describes blood in the vomit is ruling in or out the situation of shock. And for those who are medically trained, shock is a little different than what shock is inadequate tissue perfusion. So the questions that are going to come up are things like, are you dizzy upon standing? Are you feeling like you're going to pass out? And skin coloration. Are they sweating in a cold sweat? So signs and symptoms of low perfusion state. The red, the green shows the emergency exit. So if it's yes to any signs and symptoms of shock, it's a 911. Whoops, you got to us by mistake. Let's just shift you right back. If you get a no to shock, there's some other questions that are asked. Still can go 911. No again. To abdominal trauma, all the no's keep going down. The more questions in general, the lower acuity you're going to expect this to be because we rule out the high acuity conditions first. And that makes sense too because if something's high acuity, you want to exit that phone call and get them help. And at the end of a call, this abdominal pain call could be, well, you know what? It's 11 o'clock at night, and you are having some symptoms that are somewhat concerning. So probably an ED is going to be the best place for you, but can your roommate take you? Are you comfortable with this? Are you comfortable with that? Is there a way you can get there? You don't want them driving in if they're in pain, but is there another way that they could get there? So this is a little bit about low code. And low code, again, is that software program. Oops, sorry. I'm used to wandering around the room when I teach. Is that software program that houses the protocols. The low acuity calls very often end up being about 15 to 20% of an agency's call volume. The average call duration is usually between 8 to 15 minutes. And we do call reviews, and we train nurses within the agency that become certified in this to become what we call QRs, which are case reviewers, because we do believe that feedback and rapid feedback is very important. If you've got nurses doing this really well, they need to know, keep doing it like you're doing it. If you've got nurses that need to improve in a couple of areas, they need to know that as well, and the sooner the better. And turn around any bad habits or stop them from forming. Percentage of calls using ECNS that end up with an alternative disposition other than an ambulance transport or an ED, close to 50%. There are studies that will tell you it's higher than that. And it depends, again, what comes in, how well it's used, and how they're trained, and what hours of operation. That is another thing you're going to want to look at is what times of day do the lower acuity calls come in. Alternative dispositions to transportation. In the U.S. alone, between 32 and 62%. So that's just saving on ambulance transport time, getting people, even some of them, to the EDs. So here's where the agencies are currently in the United States at MedStar, Fort Worth, REMSA, Reno, and Northwell Health Services in Long Island, New York. Internationally, Canada, Niagara. You've got the United Kingdom, South Africa, Botswana, Australia, and Austria. And I'm excited about that one. I get to go to Vienna 4 times next year. And I get to go with Dr. Conrad, so it's like bonus. So one of the questions that the gentleman who was doing a little interview with me earlier asked, and this is an excellent question, is how do you deal with the perception of the public that what they're getting is good and it's not just we're trying to gatekeep here and keep you out of the 911 system? And this is going to rely really heavily on you guys. It's going to be your community outreach. There's been a nice template for you developed with the grant that REMSA received on how they did some community outreach, and they've been very good partners to help other people look at how do we get the word out and educate the public. But the biggest thing is going to be word of mouth. REMSA found themselves in an interesting situation where callers started calling from other states because the word got out. So they started getting calls from California and some other areas. In the UK, when customers were queried as to their experience, 84% of them all said they were treated with kindness and respect. 11 said some of the time that happened, and then 5% didn't feel they were. The little pie chart over on the other side is interesting because that tells you, well, then how effective was it to use this system with regard to getting them to the right place? And you can see that 86% of them did not contact the EMS within 7 days. And if there was a true emergency going on, you would expect that there would have been a contact sooner. Sometimes there's a contact sooner even though there isn't an emergency, but some other need wasn't met. Here's some results from MedStar in Fort Worth, Texas. 90% of their callers indicated that it helped talking to a nurse. When I've reviewed some of the calls that come in, it's a large percentage, and I'd love to pull the report on this, are mothers and fathers on their children. They just need that little bit of extra, this is going on, and that little bit of advice. Often they intuitively kind of know maybe it's okay, and they do really well self-triage. People actually do well self-triaging if they've got another option. 86% stated that their condition got better. 77% stated they do not believe the call should have been handled any differently. And the satisfaction scores were typically greater than 4.5 on a 1 to 5 Likert scale. And here are REMSA's rates in Reno from July 2014 to June 2015. And again, you've got very high levels of satisfaction. And in looking at putting this program together, and it looks like you've already started the groundwork here too, looking at who your partners are. And here are some potential partners that we've seen people reach out to and who have gotten on board with this concept. Grants, hospitals have got a vested interest, physician groups, insurance companies, other partners, and as a cost avoidance justification. And what we mean when we say that is sometimes the savings are behind rather than up front for not dispatching a crew, for not paying people overtime to staff the ambulances because they're all going out when maybe some of them don't need to. So I want to talk a little bit about your neighbor over in Reno, REMSA. They were fortunate enough to receive a $10 million CMS grant. Not everyone gets one. In fact, I don't know if anyone else did. Very big grant under the Affordable Care Act. The focus, like yours, was on community health, innovation to improve the access to care, and also the appropriate care, and then the third, to reduce the overall costs. And it follows the IHI's triple aim, which is to improve the patient experience, health in the population, and then reduce the per capita costs. Kind of ambitious, but we think it can be done. So here's what REMSA did. They looked at a three-prong approach. They looked at alternatives to ambulance transport, they looked at implementing community health paramedics, and then they looked at implementing the Nurse Health Line, which is Dr. Fivas and our program. The alternative ambulance transport looked at how else do we get people to destinations. Community health paramedics were, can we send people out trained paramedics with different equipment, some medications, different training, and help them, especially with some of the chronic conditions that reemerge and are a large part of readmission to hospitals. And then the nurse helpline. Now, in addition to taking calls that come over from 911 and meet that criteria in the pink box that then go to the nurse, what REMSA did was implemented a direct dial line that the public could then call this number in order to speak with a nurse. And it's that 7-digit line that is the majority of the 2,500 calls they now get a month. Here's some interesting things that they found out through having that grant funding and doing the research that they're getting ready to publish. A super user. A super user is an individual who has visited an emergency department 12 or more times in a 12-month period. And if you look at this in their county, they identified 953 individuals in that county that accounted for just those 953 people over 20,000 ED visits, $65 million total hospital charges. And when they further carved down, they found out that 28% of these individuals were uninsured, 29% were Medicaid, and then 19% were Medicare. And they found out that 46% lived in one of 3 county zip codes. So there is certainly some cultural influence that goes on into the decisions to call 911, as well as resource availability. So in the preliminary results, again, they have not yet been published, but we're thinking that's coming out very soon. Their call volume quadrupled from November to June. And as of June 2015, it's over 2,000, and the last I heard was between 23 and 25 each month. They figure that they avoided over 3,000 ED visits, and to date this would be bigger numbers than this. 436 ambulance transports avoided, and less than 2% transfer rate of ECNS calls back to 911. Cost savings of nearly $4 million. So here's what REMSA shares with us on the lessons that they've learned. They said there was an extraordinary community demand across a very broad spectrum of people needing different access. Independent call review reported high protocol compliance by nurses, and I can attest to that. I was responsible for listening to a lot of those. No adverse outcomes from using the ECNS protocols, and we can stand by that to date, despite the fact that there's 80 million calls out there. We are not aware of a bad outcome when the protocol has been followed. We are aware of some where things weren't followed, and it would have been more fortunate had they been. And we're also aware of in other countries where different personnel and different systems are used that they do not have these kind of results. But we are really kind of protective of this little system. We need for good outcomes. We need to train you really well. We need it to work for your community and for us to stand by our product. And that'll come through a very tight relationship that we'll develop. Protocol-driven triage is not advice. And it outperforms the other alternatives. I recall being a nurse in the ER back in the, would have been mid-80s? No, mid-90s. I aged myself even more. And truly, the secretary would go, "Oh, nurse call." And whoever was walking by would take the call. "Hi, yeah. Oh, I tried this or that. Okay, bye." Yeah, not the best way to do it. Effective advertising campaign is key. And then it did, when REMSA looked at their savings, what Brenda Staffen reported at the Pinnacle and the EMS conferences that I attended in the last year was that the community paramedics did not hit the benchmark they had hoped. The alternative transport did not hit the benchmark they had hoped. But the nurse helpline outperformed many-fold what they expected. And at this time, I'm going to turn it over to Dr. Fivas because it's about international stuff, and he's got a great accent.
Did you guys want to take a 5-minute break? Are you good to go? 5-minute break? Go.
Gigi is here to translate for those that don't understand what I'm saying. I spent 10 years working in the UK and it did nothing to my accent, so sorry. So this is some of MedStar's data. They looked at some of the economic impact that the system is making. This is in Fort Worth, Texas. Just over 1,380 calls that's been referred to the nurse desk. That alternative dispositions to 41% of these calls coming in. So quite a significant number of alternative dispositions. And also on par what we've seen internationally. You'll see some of those figures that Gigi presented earlier showed figures of 47%. And that was the government looking at our clients in the UK using our software systems. I believe the true number being closer to 43% than 47%, because I also look at some of their data. But that's about the ballpark figure if you're doing a good job. Anything between 40 and 45% alternative dispositions. Obviously, safety is of paramount importance to us. You can try and strive for 70% alternative dispositions, but you're going to pay on the safety side. So they looked at cost savings there, total charge avoidance and total payment avoidance, coming to 1.4 and 679,000. So looking at Northwell, I'm not sure if all of you are familiar with Northwell, previously called North Shore. They're in Long Island. They recently published some of their data. They use low-code and the ECNS system slightly different. So they have a population of patients that they're looking after, and you'll notice there that this is an interesting population with high rates of dementia, decubitus ulcers, diabetes, COPD. So people with chronic diseases that's sometimes difficult to manage, and also high-cost diseases. Patients like this is often in the hospital, they get discharged, and they get readmitted. And I believe there's now some incentives for the hospitals to make sure that these patients aren't readmitted within a 30-day period. And this was part of their objective, is to make sure that these patients are cared for better in the community. So they have an outreach program where community health paramedics would visit these individuals. They have the nurses with the ECNS program where they would get the initial call if there's any new symptoms or change in their current symptoms, and they would then manage them accordingly. And on this recently published material, they documented an estimated financial savings of over $7 million using this approach. ECNS, only one component of the implementation in Long Island. What's important to highlight there also that it's a zero clinical defect rate, and that is zero reported adverse incidents, which is really important to us. So our protocols in Australia, we first implemented there in 2006 in the state of Queensland. They've got a nurse advice line centre in Brisbane, implemented there in 2006. They cover a small population, just over 4, I think it's now 4.5 million people in the state of Queensland. 120 nurses working in that call centre, about 40 workstations. Some of the data I want to share with you, it's not very recent data. Usually when I go there, I just train nurses. I don't look at their data too often, but what I have on me here is a breakdown of their end dispositions. Remember, these are not people that dialed 911 and were then transferred to a nurse. These are people that dialed straight into the nurse. So they kind of self-triage themselves. And about 200,000 calls, with 9,200 of them getting upgraded for an ambulance dispatch. So that's about 4.6% of that call volume getting an ambulance. About 17% of them were sent to the emergency department, mostly, on their own steam, drive themselves or get somebody else to drive them. And then the balance of their calls ended up with alternative dispositions. So you can see that the alternative disposition rate with a typical 7-digit nurse advice line call is quite different than you would expect from a call going via your 911 system, ending up as a low acuity call and then referred on to the nurse. What it tells us is that people are fairly good at self-triaging. So there's a breakdown of the other alternatives people accessed in Queensland. So with any one of these type of products, it's extremely important to make sure that we do quality assurance and quality improvement. And this is an ongoing process. We use Aqua. Aqua is another software system that's familiar with the fire department. They use the same software system to do quality assurance and quality improvement on their 911 calls. It generates QA and QI reports, and we use that to feed back to the individuals on their performance. It's a 2-day course where we can train individuals in the agency, nurses, to do this quality assurance and quality improvement work at your agency. There's a 20-point accreditation plan, similar to what the fire department have been committed to on the 911 call side. So we can do a similar exercise to make sure that we adhere to the utmost quality measures. So we also have a national queue program. Gigi has mentioned she's done numerous of calls, and then when there's really interesting calls or debatable calls, she brings me in. And that's a learning exercise for everybody in feedback to the individual nurses and the agency. So we're heavily involved in research. I think we published about 9 original research articles in the last 2 years. This is just one abstract that we submitted to the, this was the 8th European Congress of Emergency Medicine. This one was held in Amsterdam, and we were fortunately enough to be the successful candidate to win this, this award. The theme that we submitted was using EMS telephone triage data to assess the amount of resources saved through telephonic triage. There's some of the statistics. Just over 2.6 million calls we looked at. About 90,000 of them were considered dealt with by hear and treat. So we didn't send any resources to these individuals. We saved a total unit hours of 135,000. So a significant number of unit hours. If you think those ambulances are available now to respond to more urgent cases, those people that really need the ambulance. Gigi mentioned earlier that emergency departments are being overrun. They also noticed this in England and in Australia. They call it congestion block. They can't get the people through the emergency department fast enough. That means ambulances are waiting outside to offload patients, contribute to their long cycle times. But also it saved approximately 28 million US dollars, about 22 million pounds sterling for the NHS. So we're always aware of emerging threats and pandemics. The most recent scare with Ebola. We have the ability to quickly adapt our protocols to counteract some of these threats that we're dealing with. Feels like every other year we get confronted with some other virus or bacteria or fungi around. In 2001, we incorporated even questions about anthrax in our protocol. Also, I don't know, remember, some of you might remember, I think it was Navigator 2008, it might even have been here, where Swine flu just kicked off in April. We were all at the Navigator conference, so it was quite easy for us to pull our resources together. Unfortunately, my protocol on pandemic flu was aimed at avian flu with a much higher morbidity and mortality than what was present with swine flu. So within a 48-hour time frame, we managed to change our algorithm and change the gears in that to be geared for swine flu rather than avian flu. So you wonder, why did Las Vegas Fire go through the effort of becoming an ACE? ACE is a Center of Excellence, accredited Center of Excellence. It means that they're operating at extremely high levels of efficiency, safety, adherence to protocol. And that's important for us, because if we get the low acuity codes transferred from the EMDs to the nurses, we want to make sure that those are in fact low acuity codes going to the nurse. And this is one of the reasons why we expect clients that use ECNS to be ACE accredited agencies. So yeah, that's the end of it. Let's see, that's just a list of references. This is an opportunity to ask questions, have a bit of discussion. If we just leave maybe half an hour for demonstration of the software, I would like to run a call through it as a nurse would run a call through it, and just show you what happens on the nurse's end and how seamless the questions are prompted and how we get to an end disposition. Yeah, it's up to you guys. Shall we do the demo now and leave the questions for the end? Okay. Unfortunately, I have to sit there. That cable is not long enough to reach the speaker, the microphone. Will that work? Yes. Okay. So typically in the mornings when the nurses log into the system, oh, you can't see this. Yeah. This is when you have two monitors at home, and that screen is now on the other monitor that you guys can't see. I'll try and fix that. Okay. So that daily bulletin is where we can add pertinent information on, for example, outbreak of a norovirus or gastroenteritis in the community. The nurses would be alerted to the fact that there might be more calls coming from patients with these type of symptoms. Could also be used, obviously, just for administrative purposes. So I'm creating a new call. Remember that in your agency, your computer-aided dispatch system will be linked via interface to this application. So data that's been entered by the EMD, that will be demographic information, address, telephone number, will auto-populate in the system, so the nurse won't have to type it like I'm going to do here. I don't have a CAD system, unfortunately, on my laptop. Okay, so Gigi Marshall has phoned the call center, and we'll now look in the database if Gigi has called before. And we can see there's an entry for Gigi Marshall, and she's an existing client of us, so we'll select that specific record. It will then show a history of all of Gigi's previous calls, and you can see she's a frequent caller to the service. We can see the protocols that we used in the past for her, the disposition that we reached. So this is how urgently we need to attend to Gigi, and if we need to attend to her face-to-face, or is this something that we can resolve remotely over the telephone? The point of care is those resources that's available in your community. So you will set up urgent care centers, family physicians, other clinics that's accessible for these patients that call in. We can also set up a care plan for Gigi in consultation with a treating physician. So every time Gigi phones, we'll see there's a care plan available for her. We can access that care plan and then act on it if necessary. So we make sure have any of Gigi's medical conditions, allergies, or medications have changed. If so, we'll update those. So what's the problem today? Let's say Gigi hurt her ankle again. How long has the problem been there? It's been 1 hour. Has she seen a doctor? Not yet. Any home treatment? Yes. She tried ice and elevation of her leg. It's not helped. Is this a recurring problem? Probably, but not for this example. And then if necessary, are you in a position to use a car, taxi, or public transport? Yes. Now we have an option to select a protocol. So these protocols are based on symptoms. So we will look at symptoms and injury when we try and select the most appropriate protocol. We spend almost a day with the nurses teaching them how to select the most appropriate protocol. So we can select from an alphabetical list, or we can type in a predictive text search. So if I type in ankle, we'll get everything to do with ankle. So there's ankle injury, which we'll use for this example, but there might also be ankle edema, ankle pain or swelling, or swollen ankles. So swollen ankles, we'll think of congestive cardiac failure, kidney failure, other types of medical conditions that will cause edematous states of the ankles. Ankle pain or swelling, we'll think of inflammatory conditions or infection as a cause when we enter that specific protocol. But we're after the injury one. So that's the condition we're trying to exclude with this specific question. We're looking for an obvious fracture of that ankle, so that ankle is going at a different direction than it used to after the injury. So we'll ask these questions. Every one of these questions have a clinical rationale. If the nurse is not sure why she's asking these questions, you can have a glance at the clinical rationale. Let's just make that a little bit larger, the font. So say, for example, none of these are present. We're going to select no. Now we're looking for neurovascular compromise. So the nurse can't ask that question to a layperson because they won't know what it means, many of the lay people. But what we can do is ask it in a language that's understandable to the caller. If none of that are present, we're going to say no to that. And now we're looking at high energy factors that was involved in this injury. Were there high levels of injury involved, energy involved? If not, say no. Is there an open wound or cut present? If I say yes to this question, it will go on to numerous other questions involved with an open cut or laceration to the specific injury. But this is not the case. So you'll see I'm in question 4 of potential 53 questions. If I say no here, I just cut out about 24 questions, 25 questions on a side branch of the specific algorithm we're working with. Did you twist or fall on the ankle? Yes. Are you unable to stand on the affected limb? Meaning, can they weight bear? We know that if people can't weight bear on an ankle after an injury, it's likely that there might be an underlying fracture or injury. So I'm going to say yes, unable to stand. And now what we come up with is a disposition which says, seek face-to-face care within 1 to 4 hours. So this patient needs to be seen by a physician within 1 to 4 hours. Please stay on the line with me and I'll give you further information on what the next steps are. That's set in the system. That's our protocol. The nurse can override that decision and make it more urgent or less urgent, depending on her clinical judgment. The point of care are those resources in your community where we will be able to see this patient within that time frame. And this is customer modifiable because some areas have many options, others might only have an urgent care center as an alternative. So I'm now going to select the urgent care center here. And now what it does, it looks on a Google map to see, is that the location of the patient? I'm going to confirm, yes, I'm the corner of Regent Street and 100 South. So I confirm that. And now it's plotting on a map where urgent care centers are that's open and available to see this individual. You can see there's an Instacare 1.4 miles away from, this is our head office. I just populated this little database of our directory of services. There's services, there's radiology available, so I know that if I send the patient there and they need x-rays, that an x-ray will be a possibility at that venue. If I go into that urgent care center, I can also see what type of health insurance do they accept at that. So if we document the patient's health insurance, we can actually only show those resources that's available that will actually accept that health insurance so that we don't send the patient there unnecessarily. The facility tags are, for example, well, at this specific agency, they speak multiple languages, and they can list the languages that they can accommodate at that specific venue. So I'm going to recommend that we go to the Instacare. They are open, and it's only 1.4 miles away from this individual. I'm going to recommend that. And now I'm going to give interim self-care instructions. What can this patient do in the interim while they're making their way there or waiting to go there or to be seen? And these are evidence-based, simple, straightforward, easy to recommend interim self-care instructions. We typically give about 3 to 5 of these. They're easy to remember. And we just always give the worsening instruction. So if any of the symptoms change or there's new symptoms, please call us back, or if it's an emergency, dial 911. We're going to complete our call. We can now schedule an outbound follow-up. This is up to the agency if they want to do this. And you can phone the patient back in 2 days, 5 days, a week to find out, did they follow your advice? Did they actually go to the Instacare where you recommended them to go? So you're not going to schedule. And then case exit questions. Do you understand the advice given to you? Yes. And any other question you would like to ask that your agency decided is important to know. Again, customizable component of the software. So this then creates a call log of the interaction with the patient or caller, and it will have the demographic detail, all of the current medical conditions, allergies, medications they use, the algorithm we accessed or protocol, the questions we've asked, the answers we got to those questions, how quickly we recommended they see somebody and where. And all we have to do is then accept the call log, and that will then send a message back to the CAD system, the computer-aided dispatch system, that this case is closed. No resources are needed for this specific patient.
Now that might seem, I don't know if this is on. Is it okay? That might seem like, well, wow, that's a lot of questions and things, but how it really unfolds when it's not broken down like a demo. I was playing tennis, I stepped on a tennis ball and rolled my ankle. A lot of those questions are answered for me up front, and I can go ahead and say it was this. It wasn't a fall from 6 feet, and I can hit the answers because I was already told what it is or isn't. So it really does not stretch out as long as it seems like in the demo. There's much more information you get up front when the person tells you what happened that you can then answer accordingly. And then the things that you don't know, of course, you do ask those questions. Sure.
Does anyone have any questions? I'll bring the microphone around to you. Hang on a second, Nancy.
Yes, 30% of our population here is Hispanic. What do you do about callers who speak a different language?
Do you want to answer that?
The language line.
We have a service called Language Line, so we would just have an interpreter, and we can actually get any language that the caller needs to use at that time.
Can you go ahead and state who you are?
I'm Ashanti Gray. I'm the training specialist at Las Vegas Fire and Rescue in the center.
So that's how they would train them to use that line, because that's our system.
Can I just make a comment on that?
Oh, go ahead and.
Sure. So this system was in operation at LAS, London Ambulance Service, for almost a decade. Very cosmopolitan mix of people living in London, many different languages. Experience taught us that in Language Line is good. It's good up to a point. We teach around this subject and make sure that the nurses just have that little bit more wariness of the school, because sometimes stuff gets lost in translation.
Next question? There's got to be another question.
Just two questions. One is, what's the average length of time of a nurse call?
Now that differ. Anything from about 8 to 15 minutes. We had some calls going into 40 minutes. Typically, the more questions you ask, the lower the disposition you reach in our protocols. So if you do end up asking a lot of questions, it's most likely going to end up in a low acuity call. All of our urgent questions, high acuity questions, are asked early in hierarchical order, so we make sure that we don't waste any time for people that need urgent ambulance.
Okay. Second question is have any of the hospitals or primary care doctors asked to be integrated with your software so that they get some demographic information or stuff like that? Or is it completely independent?
So I can only speak now for the United Kingdom. What we do in Southwest Ambulance Trust, one of the more busier trusts, they do about 100,000 calls a year on the system. By 8 o'clock the following morning, every contact with a patient, these call logs that's generated at the end of a call gets emailed to that individual's physician.
We have a question here.
Yep. I'm Richie Dublechamp with United Healthcare. And how do you integrate with the MCO's own TAN line 24-hour hotline nurses for follow-up care?
It's a good question. Is this post the triage? Are you
Correct.
talking?
Yeah, once you're done.
Again, it's probably it's nothing that we've done before in the United States. I think if we make sure that our data that we send to those physician groups are encrypted, I don't see an issue from a technology point of view why we can't get the information to them.
Should have worn my Heelys today.
Can you tell me if there's any research or anything on how this works with the homeless population?
Yeah, we've not done any research on that aspect.
Has your information integrated with the Veterans Healthcare System?
On what level?
As far as resources and referral when you refer patients?
Sure. Okay.
Sure, I will. So we're getting a lot of local questions and even integration with the TAN line. As you saw there, you could look at care management plans for the different patients, right? So when we talk about what resources are available, and you saw the interactive map, and all of that stuff can be populated into the system, and we can redirect these people through our community to the most appropriate resource that's appropriate for who they are, where they come from, their socioeconomic, their insurance coverage. As you saw, all of that is very customizable down to the patient type.
You also asked a question about the homeless and such as that. We certainly can work out a system where they get then referred to the social worker, referred to a different way, and we find a way to hook up with them. We've done that in the past where we know we usually find them at this intersection or at this place, and we set it up that way.
Absolutely.
Does the software provide different questions or different protocols based on age, like for children, for example?
Yeah, very good question. Yeah, we actually accommodate for all the ages, newborns, infants, toddlers, children, adults, and geriatric patients. We consider that over 65. I think we'll soon move that number up. People are healthier, older. But yeah, we accommodate for all of that, and we also accommodate for the different sexes, obviously. So there's specific protocols for pregnancy, specific protocols orientated to the various urogenital problems that we run into.
Kathy Davenport, the Community Coalition for Oral Health and Nevada Dental Benefits. So on the insurance side, I know we have a lot of problems with dental issues going to the emergency room rather than having them actually go to the dental community, and that's a concern. So when you go through the system, and a lot of the different plans have different eligibility, I'm assuming we can write that all in as well so we get them directed to the right place as far as their care?
Yeah, so that will depend on what we document as the insurance plan on the system, and then having those resources documented in the point of care, so they are available for the nurse to select.
Okay.
It will take a bit of work to do it, but it's not impossible to do. Also, we do accommodate dental problems, toothache, bleeding, post-surgery. Numerous aspects are covered as far as dental protocols go in the system.
Thank you very much.
Hi, Kelly Crawford, Executive Director of Nursing at Healthcare Partners of Nevada. What has been the impact of increased phone calls to 911 for patients who end up wanting to talk to the nurse?
Yeah.
And again, that's how we design the program as a community, right? So the REMSA had the 7-digit direct number. We've talked about using other ways of getting calls to this nurse rather than through the 911 system, so they can come in either way. It can be a 911 redirect or a direct call to that nurse. And we've discussed transferring calls from Nevada 211 or from 311 rather than coming through the 911 system. So that would hopefully divert that. And when we talked earlier too about marketing, and marketing is the key, right? So if initially we want to start with just a 911 redirect, it's not really advertised as this resource to the community. It's advertised as a resource to the community when they can call that nurse directly and when we're ready at that stage of implementation.
Yeah, the problem with REMSA is when they opened the 7-digit, they did both a 911 low acuity entry point as well as the 7-digit, and they underestimated by 10-fold the number of calls coming into the call center. A huge community demand. And then doctors would switch their out-of-hours answering machines to dial through to REMSA as well, and out-of-state as well.
Hi, Dave Slattery, Medical Director for Las Vegas Fire Rescue. So first of all, brilliant. Thank you for bringing this to our community. We're really excited about this, just the potential. I have 2 quick questions. One, on the initial algorithm that you just walked us through, it looked like the first step seemed to be a transportation availability or feasibility for that patient decision point. Is that correct?
Yeah, he was talking about early on in the algorithm, the questions that were asked were, can you make it, can you drive yourself to the ER? Do you have transportation? Yeah. those are asked on the intake.
So the question is, if that, I thought it was, what happens when the patient says, no, I don't have a ride? Certainly it seems like there's a lot of opportunity to provide other means of transportation. Maybe we miss out on that interrogation of that call. I was just wondering about the rationale behind that.
So that question is part of our pre-triage questions, and those are, again, customer modifiable. This is just what one of our clients in the United Kingdom asked as a pre-triage question, just to gauge where we are with this patient before we even get into the protocol. So nothing really to do with the protocol as such, the clinical protocol, but it's just a conduit into the protocol. But if you have alternative like taxi vouchers or any of those type of schemes available, a deal with Uber perhaps to transport patients, those would be options if the patient said, sorry, I don't have my own transport. We're also conscious that some patients, although not drastically ill and they need to go to urgent care center and they're vomiting, that's one of the things that we would not use public transport for, advise public transport for.
Second question is just looking at the future for the council. Certainly we love hearing most of the alpha calls are appropriate for this, but we believe there's probably a target for some of the Bravos. So I just was wondering about the council's thought on that and the future.
Interesting that you mentioned that. We already have clients in the UK that's doing this off-label in terms of sending Bravos to the nurse. Obviously, the council wants to have the evidence base behind that, and as soon, like we did with the Alpha study, we spent many months looking at those almost 17,000 calls and what the paramedics found on scene, what the vital signs have said, and I guess our next step will be to look at some of those Bravos and see what did the paramedics find on scene, and incorporate some of those Bravos. But I do agree. It's definitely in our scope. We're looking at it, and as soon as we have the evidence, we can go ahead.
Hi, my name is Louis Lacey. I'm with the Mobile Crisis Outreach Team. My question is, does your system have the capability to flag somebody that's a frequent user, or maybe to identify those that have mental health needs so that you can just immediately like shift them maybe to another section?
Yeah, one of our problems in the past, we didn't have a resource like yours that you offer, and communities without that type of resource, we can send them, but they don't have that resource. That was the shortcoming in the system, is having somebody to send these individuals. We can identify them, but getting them help, that was the difficult bit.
I wanted to say a little more about, Louis, your question. Like Dr. Conrad is saying, a lot of this is dependent upon us as a community populating this system with as much information as possible, and then having those alternative resources available and working out those partnerships with everybody from RTC and public transportation to mobile crisis teams. You know, and so when we talk about tracking certain individuals through our system so that we can really identify who they are when they're calling and send them to a more appropriate resource that's actually going to meet their needs and have improved outcomes, this system has that potentiality. We just have to, as a community, back-build it and make it as strong as possible.
That's actually, you know, where our system typically gives a time-sensitive disposition as our first tier. But this is one of the kind of anomalies in our system, is we will actually, some of the patients will be advised to a mental health team or crisis team would be one of our dispositions, rather than just a point of care.
So another program that we have in our community called Las Vegas CHIPS, and it's currently, many of you are familiar with it, but it's a social service referral program where we're receiving referrals from our first responders, and in the last couple of weeks we actually opened it up to our communications center as well, so now we're receiving referrals from our communications center. And they're being referred to, what we currently have is volunteers and social work students at UNLV completing their practicum requirement for their degree. And so clients that are frequently using the system or inappropriately using the system because they have social need, or appropriately using the system but have complicated needs, are then later followed up with our social work students and volunteers to connect them with all the resources that are available in this community, but it's often a very complicated system to try to navigate ourselves through, and it requires advocacy. right? People need advocates as they're trying to get these resources. And so and now we've just partnered with the UNLV School of Nursing. We just are about 3/4 of the way through our first semester in a pilot program where those clients that are volunteers and social work students have identified as having complicated comorbidities or maybe would benefit from a home health safety analysis, many mental health assessments, non-invasive, but additional information with a nursing perspective. So they gather that information, make their recommendations, take it back to our social work students and volunteers, and then they facilitate all that referral processing for these clients. So that's Las Vegas CHIPS, and that could also be partnered with this ECNS program. So the referrals that we're receiving from the 911 center, as those calls get shifted over to the ECN or directly to the ECN, we can identify those high-frequency users, and behind the scenes, not even asking the nurse to do that, can get over to Las Vegas CHIPS that will then make those connections in the community.
My name is Jane Shelley. I was formerly here with the Health District. How has this affected diversion or divert problems within communities?
The 911 divert, where you can't get to a particular ER.
Oh. Well, the 911 diversions, I guess you mean hospital diversions, where our EMS providers are in the field trying to go to a hospital and they're told no because they're busy. So he spoke about, and so did Gigi, about when you have so many calls coming through a system and these people maybe don't have high needs, but they're taking up beds, right? And so your EMS providers are experiencing longer times on each calls, longer times before being able to transfer these patients. The emergency rooms are crowded and overwhelmed. And so if we can properly re-navigate these individuals in our community and have alternative dispositions such as care as home or 1 to 4 hours at a clinic around the corner and provide that transportation. However we can more properly navigate them with that reduction in call volume in our system, it will help with the hospital diversion issues that we've had in the past.
Yeah, we didn't study that in detail as a published study or anything like that. It's just anecdotal that we've observed this trend just about everywhere in the world, where EDs are completely congestion blocked, and the knock-on effects that it have on the EMS systems. But no published studies that I'm aware of that we were involved where our system was part of the solution.
And with regard to the diversion, we were actually approached by a doctor from another country. I'm not going to say what because I don't really want to out them. But what their current practice is that about 50% of every call coming in, they just listen to it and go, there'll be no one coming. So you're going to need to be coming up with another plan. So this is worldwide, this problem of there are not enough resources. Here in the United States, that wouldn't fly. But in other countries, that's literally their backup plan is there won't be anyone. So you're going to need to come up with another plan.
Yeah, also in answer to that, it'll be easier to collect the data since it's just going to go through the 911 call system. There isn't the secondary number where they can call in. So collecting that data as to how many reduction in transports, even looking at their high frequency users, it'll be easier to collect that. Anyone? Any more questions? Yes, ma'am.
Thank you. Hi, Adi Flores Fernandez with Dignity Health, St. Rose. And I have two questions. The first one, you spoke about follow-up calls. So after the call, then I'm assuming is the same nurse that took that call the one responsible for doing the follow-up call?
Not necessarily. They have the option to place that follow-up call in their personal queue, or they can put it in the general queue. When they exit for the day, they will be warned that you've got a callback scheduled for a day or two in your own queue. Do you want to keep it there? So it depends on individual nurses. Follow-up call can be made by any of the nurses because they've got a complete call log with the interaction with the patient. And on the setting, when we schedule a follow-up call, we can give a reason, what do we intend finding out with our follow-up call? So that can be documented for another nurse that was not part of that original call.
Great, thank you. And the second one is, I guess, more of a local question. How would the community resources be gathered and loaded into the system and then updated as well?
Just from our point of view, the company that supplies the directory of services will be on site they will give you a template of a spreadsheet where the information needs to be loaded onto. Once that information, and that's I guess what you guys will discuss, how that information ends up in the spreadsheet in that format, will then be loaded into the directory of services, and then they will give you access to maintain that information on an administration utility that's part of their directory of services. Going forward, they're looking at giving web-based access to suppliers out there, for example, family physicians, clinics, to update their information and keep that that database updated remotely via external application.
And just to follow up, that again, that would obviously involve a lot of community involvement and support. And as we work with the different payer groups and providers in the community, you know, we collectively have to take that responsibility of making sure that the information in the system is accurate and updated.
Any more questions? Yes, ma'am.
I know one of the issues we have is drug abuse in the community, and a lot of times we'll have people go in and they'll ask for drugs in the emergency room. Is there any way to track that into the overall picture, saying you've got Mary that's coming in, she's had an ankle injury, she's requested Oxycontin, or so that we can try to track some of the people that have problems in our system, in this system, or is that impossible to do?
Do you have a statute through your Department of Licensing on what information you can share with regard to that? I know that, like in Utah, the Department of Licensing, every narcotic prescribed in whatever ER, the doc can go in and pull that up and see, oh, they've been shopping, they've hit these other ones in the state.
I think we started something like that in October of November of last year, where every Schedule I narc has to be registered, and you can look up and see what people.
Yeah. And
I'm not totally familiar, but I believe that was passed last year. Anyone
and that's
else?
Usually through
yes,
some
it was.
Kind of, yeah, that's usually through some kind of entity like that that you would be tracking. Yes,
Right.
and they're involved. Mm-hmm. And I know in California, we couldn't even put it down on an index card in the ER. It's like, no.
Hi, Loretta Moses with the Clark County Medical Society, and thank you. I agree with Dr. Slatter. This is a great program to bring to our community. To be involved in it, is there a fee to be involved, or do you just sign up? I'm kind of curious, and I'm to be involved and be able to get your data put in so that you're one of the resources that's being used. I might have missed it in the beginning. I apologize. I came a few minutes late.
Thank you for breaking the ice on the funding piece.
Thank you.
Yeah, in a lot of ways, that's kind of yet to be exactly nailed down. What we are looking for is, again, this is a community initiative. So everybody that sees any sort of benefit to either their clients, to their profession, to their bottom line is welcome to come and be a part of this. You know, we've had 4 different entities already come to the table offering to help fund a 1-year pilot at limited implementation. We believe that at full implementation, this is going to make a huge difference to our community. So the more people that are involved and help financially support this so that we can have more labor, more nurses in seats answering these phone calls. But no, we don't want it to be a fee-based to get your data in there, because then we're occluding, you know, we don't have all the right data in there. So instead, I would just, you know, please ask that if you see a value in this program, contribute however you can.
The complexity of this, even though it's a very simple linear type of thing with the algorithms, what they're talking about, like the lady with the fall, if she falls and then they find it low acuity, go see someone, great, and then she gets to the provider, here's where her insurance is, and they get in there. But these people hide a tremendous amount. Either they're used to living like that, they don't realize the dire circumstances they're in. So a simple fall can be, I need a readjustment on my lisinopril. It may also be they have a tremendous cluttered home, and by sending the Las Vegas chips out there, they can say, we need to pick up all these little scattered drugs and dog toys. Or you may realize it's a mental health issue at that point and say, you know, you're a hoarder, we really need to get you some help here. And in that way, you'll stop falling. So it's or they get into a fall prevention program and it's balanced. So there's a lot of components to keep this moving, and we do need many, many people to help keep it rolling forward. And that's why she felt it was the best time, or the community really felt it was the best time to go forward, because the high level of collaboration at this time. Does anyone else have any more questions? Please. This is your line, your program. Okay, I guess that's it. Yes, sir.
There was a question about the different age groups that we cater for. You can see there currently the list of algorithms for an adult. If I open it up for children, you can see how they add to the list the various age groups that we cater for.
That it? Any more questions? Yeah, oh, a couple more.
Is this currently up and running right now, or is it starting in January?
So we are hoping for a July 1 implementation.
Okay.
And obviously that's going to depend on a couple of different things, populating the directory of resources, having the appropriate funding, identifying at what stage of implementation we want to be at. Is this a 911 redirect only? Is this based on funding 911 redirect at high volume times only? You know, so it's July 1. If we think that that's enough time for installation of the software, setting up the capital actually in the Combined Communications Center, having the consoles available, identifying staff and training them, and getting us there. I mean, that's enough time to do that. But again, in terms of how many calls that program will be able to manage is completely dependent upon funding.
As the updates come, we'll be sending out the emails, so be sure you're signed in. Be sure we have that or a card with a very legible email on it, and we will be contacting you. Also on December 14th from 2 to 4 p.m., we'll be having a second Access to Care meeting, but this one will probably be more focused on how the insurance and the provider network is going to work together to get where we know the gaps are and where we know those areas are. Not as much on this unless there's something that needs immediate attention. So please come to that also. That will be held here also.
Yeah, we'll provide an update on this program at that meeting. Also, you picked up a flyer. We're doing tours tomorrow at 8 a.m. and 10 a.m. at Las Vegas Fire and Rescue if you want to come by and check out our communications center. I'll take you next door to the fire station just to kind of give you a visual of where this will be and how it's already working and how it will work in our existing systems. So if you're interested, I have a sign-up sheet that I'll put out, so on your way out, go ahead and sign your name. And if you're interested in that it's full, then let me know and I'll